Hello friends, now I will be talking to you about Myasthenia Gravis. It is a disease of the muscles, rather you can say it is a disease of the motor end plate. Now what is the definition? First of all, it is a autoimmune disorder. As it is an autoimmune disorder, there has to be some antibodies. So there are antibodies which block acetylcholine receptor in the motor end plate, that is postsynaptic acetylcholine receptors. So as you know it very well, when the acetylcholine is released by the muscle, it acts on the motor end plate and that lead to muscle contraction. So this is the muscle, this is the motor end plate, here are the receptors, acetylcholine receptor. So these antibodies, they go, so acetylcholine is released from the muscle, and these are the antibodies. They already have blocked the receptors, thereby when acetylcholine comes, it is not able to act on the receptor, thereby muscle contraction does not occur and patient feel muscle is weak. This is the basic pathogenesis of Myasthenia gravis. Now who are the patients which are primarily involved in this? It is in females in the age of 20 to 30 years, that means young females, but in males around 60 to 70 years, that means elderly males are involved. Okay. Now what are the clinical features by which patient come to us? Typically patient come to us with evening fatigue. Patient feels too exhausted in the evening as compared to his normal colleagues. Patient has extra fatigue and muscle weakness, or patient may have fluctuating muscle weakness. But one of the most common symptom is ptosis, is one of the most common presenting feature of this disease. As far as muscle weakness is concerned, it is usually proximal muscle more than the distal muscle. So not only it involves the muscle of the limbs, it also involves motor cranial nerve, third, fourth, sixth, ninth, 10th and 12th cranial nerve, all the motor nerves are also involved. Thereby it leads to diplopia. Because of these nerves and due to diplopia patient may have difficulty in vision. As there are 9th, 10th and 12th nerves are also involved, so that lead to dysphagia. Difficulty in mastication, because muscles of mastication are involved. As muscles of mastication are involved, patient has a feeling of not able to finish meals, not able to finish the meals. Muscle of respiration may be involved, diaphragm may be involved, patient may have difficulty in breathing. Breathing difficulty. And in the patient may have nasal twang of speech. Nasal speech, also called mushy speech. Nasal twang of speech is there. And in the advanced stages, patient may have snarling face appearance because of muscle weakness. Right. In this patient, sensation, reflexes, and pupillae and accommodation reflexes, they are all normal. They are normal. This is a very important point to know. Point to noted, eye muscles are involved which lead to diplopia, but accommodation and pupillary reaction are normal. Well, what are the diseases which are associated with associated disease are, first of all, thymoma. It is there in around 10 to 20% cases. There may be thymic hyperplasia. Patient may have thyrotoxicosis. That means plus other autoimmune disease can be there in this patient. Now, what are the antibodies which are there? Antibodies which are there. First is acetylcholine receptor antibodies. They are there in around 80 to 90% cases. And these antibodies are formed in the thymus. Okay. Now, the applied part is, that's why we in many cases we prefer to do thymectomy in the treatment of myasthenia gravis. The reason being, once you remove the thymus, source of antibodies is taken away, so that patient has much better recovery. The reason is we are removing the source of antibodies. In those patients where we don't get acetylcholine antibodies, then we can go for anti-musk antibodies, that is muscle specific kinase. Okay. Well, in myasthenia patients, there are many drugs which can increase the weakness in a case of myasthenia gravis. So, let us see what are the drugs which we should not use in case of myasthenia gravis. So, drugs contraindicated in myasthenia gravis: antibiotics like aminoglycoside, quinolones, beta blockers, quinine, class 1A anti-arrhythmic drug, drugs, then non-depolarizing muscle relaxant. These are the drugs which are contraindicated in a case of myasthenia gravis. Investigation. Best initial test is acetylcholine receptor antibodies, which are there in around 80 to 90% cases. But if these antibodies are not there, then what next? The next is look for anti-musk antibodies. Now, what is the most confirmatory, most sensitive and most specific test? That is EMG. Electromyogram is the most sensitive and most specific test. Then adophomium test. Is just a screening test. Previously it was used as a initial screening test, but nowadays it is reserved only for some cases, but not a very popular test nowadays. Then repeated nerve stimulation, lead to decremental response. What do you mean by decremental response? As you are stimulating the nerve, which will lead to muscle contraction. So, initial contraction will be like this, then. What you find, the contraction is getting reduced because muscle is getting fatigued very fast. So, we are getting a decremental response. One of the important DD of myasthenia gravis is Lambert-Eaton syndrome. In Lambert-Eaton syndrome, with repeated nerve stimulation, you get a incremental response. incremental response in Lambert-Eaton syndrome. This syndrome is very frequently associated with small cell lung cancer, right? So now we have patient of myasthenia gravis. How to manage this case? If the patient has come in acute myasthenic crisis, then plasmapheresis is the treatment of choice. But remember, it is done only when patient is critically ill and has acute crisis. But otherwise, in chronic cases, or you can say not in crisis, the first drug of choice is anticholinesterase like neostigmine, pyridostigmine. Out of these, usually in clinical practice we use pyridostigmine because it has a longer half-life, so longer duration of action. But it is only a symptomatic treatment. If patient responds to this drug very well, you continue. If not, then what next? If patient not responding to this, then you can plan for thymectomy. As I told you, thymoma may be there in around 10 to 20% cases, thymoma. Thymic hyperplasia is seen in around 70% cases, thymus hyperplasia. Is all right? This is the next step. In fact, if patient not responding to anticholinesterase, then thymectomy should be done in all the patient with or without thymoma or thymus hyperplasia. Even it is not there, either of this, you go for thymectomy. Now, thymectomy is not done in above the age of 60 years, it's not done in children. It is not done if there is only ocular myasthenia is there. Only ocular myasthenia. In these conditions, we do not do thymectomy. Okay. Well, suppose we got a patient around 40 years in which we have done thymectomy and patient still not improved. Then what is the next step? After thymectomy also patient not responding to patient still have problem. Then we go for immunosuppressive therapy, and the best initial drug for immunosuppression is corticosteroids. Is the best and the first initial, and you give start a treatment, and later on you can also add azathioprine Now a word about azathioprine. It's one drug which reduces function of T cells. Point to be noted, it does not reduce the number of T cell, but it make the function reduces the function of T cell, and it is these T cells which are producing these antibodies, that is anti-cholinesterase, anti-acetylcholine receptor antibodies are being produced by these cells. So it will make the function the function less, so patient has improvement in the disease. So this is the next step that to be done once we have even thymectomy has failed. And one more thing I like to add, remember we are doing thymectomy just like what we do splenectomy in a case of ITP. So once we do splenectomy, it does not cure the disease, but it is simply symptomatic improvement. Here also once we do thymectomy, it is removing the source of antibodies. That's why patient has lot of symptomatic improvement is there. That's why not everybody is cured. Then the next line of treatment is immunosuppressive therapy. Azathioprine has another role to play. As I told you, we initially start with steroids. So you cannot go for the long term treatment of steroid in this patient. So by the time steroids start having action, we also add azathioprine. So we can wean off from the steroid once azathioprine have started acting. And the newer drug, a new immunosuppressive drug has come, mycophenolate. It's a new drug, it's a very effective drug, but and the advantage is it is less toxic as compared to azathioprine. So a quick recap, first treatment is in a, of course stable patient is always pyridostigmine. If not effective, the next step is thymectomy. Not effective, add steroids, and after that you add azathioprine. An acute crisis, you can go for plasma pheresis or you can even go for intravenous immunoglobulin also. This is all about myasthenia gravis. Thank you very much.